All right, well, thanks very much again to the organizers for allowing us to give this update. It's a very exciting time for those of us that were participating in this clinical trial. And on behalf of the investigators, including Dr. Krishnan, I'm delighted to give you this update. My obviously key disclosure is that I'm one of the global co-principal investigators of this trial. Everybody knows about the unbelievable burden of risk in the patients with chronic limb-threatening ischemia. Up to 3 million Americans are suffering from this, and the amputation rates are high, with half of these major amputations occurring unbelievably without a prior diagnostic evaluation for vascular disease. The burden of mortality is also very high, with 25% mortality at 1 year in some series and up to 60% at 5 years, with the amazing fact that diagnostic angiography alone lowers the odds of amputation by roughly 90%. So the LIFE BTK trial was undertaken because of the lack, as you've heard this morning, of a definitive therapy for the below knee segment. There's certainly a variety of current treatment options that you've surveyed this morning in the previous lectures and also during the cases. But predominantly, all of the current technologies that we have, be it angioplasty, atherectomy, drug-coated balloons, bare metal stents, coronary drug-eluting stents, have some limitations for their application below the knee, whether it's the lack of a drug, the lack of a scaffold, or the ability to leave nothing behind, particularly in these areas that are compressible, such as the infrapopliteal circulation near the ankle. So the LIFE BTK trial studies the value proposition of a drug-eluting resorbable scaffold called the Esprit BTK scaffold, which is a fully bioresorbable PLLA backbone polymeric stent that releases everolimus with similar release kinetics as the Xience coronary drug-eluting stent. There are 4 platinum markers on the ends of the scaffold that make it visible, but it's otherwise not radio opaque, and it comes with a monorail coronary style delivery system akin to coronary drug-eluting stents. The trial, that's the pivotal IDE trial for this study, has completed enrollment and will be reporting approximately 1 month from now at the TCT meetings in San Francisco as a live, late-breaking clinical trial. The objective of the trial was to evaluate the safety and efficacy of the Esprit BTK system compared to angioplasty in the planned treatment of the diseased infrapopliteal segment in patients with critical limb ischemia with up to 2 de novo lesions in separate vessels. We randomized 261 patients in 50 sites in 6 countries in a 2-to-1 ratio of Esprit to angioplasty, with a primary efficacy endpoint at 1 year of primary patency, which was freedom from restenosis by Doppler ultrasound, target vessel occlusion, amputation, as well as limb salvage. The patients will be followed over the course of 5 years in total. The primary endpoint, of course, is at 1 year, and the primary safety endpoint is freedom from major adverse limb events or perioperative death at 6 months. I was pleased to be one of the leaders of this trial with Brian DiRobertis here at Cornell and Ramon Varco, who really had pioneered this technique using the old absorbed scaffolds in Australia. Again, we enrolled patients along predominantly the United States and also along the Pacific Rim in Taiwan, Hong Kong, Singapore, New Zealand, and Australia. We talked about the primary endpoints. A lot of what has been discussed today has had to do with the differences in the different clinical trial designs and our frustrations in achieving a successful result. Here we assumed that the angioplasty patency at 1 year would be 55% and the efficacy of the Esprit BTK would be 20% better, so a delta of 20% for the primary efficacy endpoint. And again, it's a composite of freedom from CDTLR and limb salvage, binary restenosis, target vessel occlusion, and obviously avoidance of amputation. So it's a 4-component composite endpoint. Secondary endpoints that were powered included everything in the primary endpoint minus the binary restenosis by Doppler ultrasound, as well as binary restenosis alone by Doppler ultrasound. The patients that were enrolled were Rutherford-Becker's class 4 rest pain or 5 minor tissue loss. We avoided patients with calcaneal wounds, but relatively low Wi-Fi scores in general. They were allowed to be treated within the proximal 2/3 of the infrapopliteal circulation and have up to 2 de novo or balloon restenotic lesions from prior angioplasty, and they had to be 70% or greater lesions by core lab adjudication. The reference vessel diameter for the scaffold is 2.5 to 4, and the total scaffolded length was permitted to be as long as 170 millimeters. We also have a pharmacokinetic study that was required by the FDA, which has completed enrollment and has enrolled 7 subjects for the purposes of assessment of drug levels in the circulation. There's a number of unique characteristics which we think will hopefully distinguish this trial from other prior below-the-knee trials, and specifically, we did endeavor to have a diverse population. We have a population of over 40% underrepresented groups in the trial. We were very fastidious because Doppler ultrasound was the primary endpoint. We were very fastidious with getting people back for Doppler. If they had difficulty getting Doppler, we'd have the core lab coach the sites to get a diagnostic study, and we had a team, a SWAT team of technologists and research coordinators that would go to patients' homes and identify patients. My favorite story from the trial is there's an investigator in Lubbock, Texas, who'd had a patient who was out in a outlying county, and they hadn't been able to get in touch with her, so he sent the local sheriff to her house to find her and tell her to come back in for follow-up. That's how committed our investigators were to getting these patients back in the trial, and we had very, very high compliance with the protocol. We obviously had core laboratories for angiography, IVUS, OCT, and we'll have some data about intravascular imaging and its value. We obviously also had a wound core lab, which is something that I think has not been compulsory in most prior studies, and roughly half the patients were Rutherford 5. And the wound data, frankly, is incredibly fascinating, and there'll be a late-breaking clinical trial presentation at Viva looking at some of those data. The preparation for implantation of the bioresorbable scaffold, as everybody may remember from the coronary experience, is quite fastidious and was pre-specified, and the long-term follow-up will continue out till 5 years. So we're looking forward to presenting these data in almost exactly a month from today, on the 25th of October in San Francisco, and we look forward to sharing that with you at that time. But that's the update. So thanks very much.